The number one reason people are coming to see us in an outpatient setting is because they have pain, right? And so if we don't understand pain, how can we be the best people to serve them? So yes, there's a lack of knowledge. And the PTs and the PTAs that I spoke with as part of my PhD, many of them express that frustration of just not getting enough of that in their entry-level programming, and trying to, seek out further education. It's time consuming, it's, expensive. It takes a while to get caught back up. At the same time, they recognize the difficulties that other healthcare providers also don't have enough pain science education. So even if the PTs that we're talking about were super excited about their biopsychosocial approach and they were going to have these big conversations, they were often hitting up against what the patient had learned from another healthcare provider. And it's particularly if that was a physician or someone that had referred on and they were focusing on more of a surgical management perspective. And the patient tend to have a very strong biomedical perspective. And it was hard for those PTs and PTAs to kind of overcome that, right? So our conversation is not just impacted by what we bring to that visit, but it's also what the patients have encountered along the way. And so we saw that both in the systematic reviews and in the mixed method studies I had done as well. But I think that gets to the bigger point is that these conversations between individuals really are occurring within the context of clinic constraints. So many of the PTs and PTAs found it helpful when patients with similar conditions could be scheduled together, or that they were able to block off specific time, or they could have one-on-one time with a patient with chronic pain that was in a quiet setting where they could have that opportunity to interact with them and learn a bit more. So you kind of had some of these clinic factors, and the systematic reviews I did also supported that the clinic itself can either bolster trust between the provider and the patient or decrease it. So it's really interesting when we think about these bigger, broader factors. And then we get to the bigger factors, like what is it about our community and our culture that we perceive pain, right? Because pain is so ubiquitous. We all experience pain, but unless you've actually had chronic pain yourself, it's really hard to kind of conceptualize this invisible disease that doesn't have the imaging to support them. And we start to stigmatize, implicitly become distrustful in our society about what that means when a patient doesn't have imaging results that could support what their complaints are. Like, then we start to create negative stories, like, why is this happening and why are they here and what do they really want? Right. And so we kind of fall into this. And because then things don't line up from our biomedical to biopsychosocial approach, they don't line up with the imaging, we do create some stigma. And when we have stigma, that actually erases our ability to empathize. And when we can't empathize, then we start to negatively stereotype more. Right. And so we've kind of got ourselves into this vicious cycle of where we kind of get lost understanding the patient. So there's all these big, broad factors that can influence our conversation. And we haven't even got to like the cultural differences yet. So, right. So like how I experience pain in my family may be quite different than how your family experience pain.